Okay, good morning, everybody. My name is Brooke Barton. I'm a third-year medical student at the University of Washington, and today I'm going to share a case with you called maternal cardiac arrest secondary to avulsion of the ovarian vein from the IVC from the Department of Obstetrics and Gynecology at the UW. So a bit of background, maternal cardiac arrest is in general a rare complication, but when it does occur, it has a really high mortality rate. The most common cause of maternal cardiac arrest is hemorrhagic shock due to postpartum hemorrhage. And the most common cause of postpartum hemorrhage is usually uterine atony. But today I'm presenting to you an undocumented cause of postpartum hemorrhage, and that's avulsion of the ovarian vein from the level of the IVC. So diving right into the case, the patient is a 38-year-old G5P4 admitted at 40 weeks and 1 day for induction. Her pregnancy was complicated by substance use disorder, preeclampsia with severe features, and KEL isoimmunization. And she also had a history of postpartum hemorrhage in a prior pregnancy due to rupture of a left ovarian pseudoaneurysm, which is interesting to note. Her labor course was unremarkable, and she had a healthy male infant who's still doing well today. And she did have a greater than expected blood loss at the time of delivery, around 550 milliliters. So not classified as a hemorrhage at this time, but she was given prophylactic uterotonics right after delivery. So flash forward 10 hours later, she was found by nursing staff to have altered mental status and diffuse abdominal pain. So nursing staff immediately paged the OB 911 phone, and within 2 to 5 minutes, the whole OB team on call was at the bedside. Bedside ultrasound revealed significant bladder distension. They thought maybe that was the cause of her abdominal pain. So they drained it and they got over a liter of clear normal urine out. Shortly after they drained her bladder, her vital signs absolutely tanked and she went into cardiorespiratory arrest. So then they called in the code team, which included anesthesiologists, respiratory therapy, pharmacy, etc. And resuscitation efforts, achieved ROSC within 2 minutes. So when she was stable again, they thought she was having a bleed somewhere. They didn't know where it was at this time, so they went for CT. And CT showed a large right retroperitoneal, extraperitoneal hematoma with extension into the mesentery, measuring a whopping 21.5 by 15 centimeters. So when we look at the image on the right, we can see the size of the hematoma indicated by the gold star, and that it is so big, it is laterally displacing her normal anatomy. Her uterus is identified by the purple star. So this is a great picture because it shows you the extent of the hematoma and how it is changing her anatomy due to its size. But it doesn't tell you where the bleed is coming from. So she needed to go for an exploratory laparotomy with, again, another multidisciplinary team, including maternal fetal medicine, gynonc, and vascular surgery. And so during the surgery, they found 3.5 liters of retroperitoneal hematoma inside of her abdomen, secondary to avulsion of the right ovarian vein at the level of the IVC. So in other words, her right ovarian vein essentially fell off of the IVC, leaving a big gaping hole in her inferior vena cava and allowing this blood to accumulate rapidly. Of note, it's also interesting to hear that vascular surgery's theory, they believe that her distended bladder was tamponading the bleed. So when her bladder was super big, it was putting on that positive pressure onto the hole in the IVC. And so then when that pressure was removed, that's what allowed for her rapid decompensation. But she had successful repair of the IVC. She had a right salpingoophorectomy and a left salpingectomy. As for outcome and follow-up, her outcome was extremely favorable. She was discharged in good health 4 days later after this incident. And all of the credit for her well-being in a successful resuscitation after a cardiac arrest is due to the early detection from the OB nursing and OB 911 staff and multidisciplinary management that happened quickly. We can go through the case and see the number of specialties that were involved in her care within a couple of minutes. And also, given her history of 2 vascular events leading to postpartum hemorrhages, this avulsion and then her prior pseudoaneurysm rupture, they sent a arterial aneurysm and collagen panel, and they were both negative. Now, do I believe that this patient's vasculature is normal? No, but we only know what our test can tell us at this time. So in summary, as a result of this case, I hope that medical providers are now able to include vascular abnormalities as a differential diagnosis for postpartum hemorrhage in a patient presenting with acute abdomen. Recognize the importance of early involvement of a multidisciplinary team to ensure and improve maternal outcomes in patient undergoing cardiorespiratory arrest. And I think that's the main takeaway from this case. This is a successful story of cardiac arrest where the team presented immediately and they were trained well to respond appropriately. And finally, consider patients with history of postpartum hemorrhage as high risk and monitor appropriately during the immediate postpartum period. And for that, we can thank the nursing staff in this case for being so hands-on and identifying when something was going wrong. So thank you for listening, and I'd like to answer any questions.
Great, thank you so much, Brooke. Do we have any questions for Brooke in the audience? Alrighty, thank you so much.
Thank you.